Good evening and welcome. Thanks for joining us. My name is Dr. Chris Pelt. I'm from the University of Utah, broadcasting here in Park City, and I am delighted to have you all join us for this evening's master class on Aurum technology, and the implant and technology that's been designed by Total Joint Orthopedics. I think it's a really timely subject as we continue to look for answers in the ongoing issue of metallosis, as well as allergy sensitivity, but also a premium bearing option that may even start to get at some of these issues that we continue to struggle with in the issues of satisfaction following total knee arthroplasty. I want to just make note that there's a Category 4 hurricane making landfall in Florida right now. So our thoughts go out to all of our participants that may not be able to join us, but might view us at a later time, and all of our colleagues down in Florida. I also wanted to acknowledge Dr. Bolognese, a good friend and colleague from Duke University, who was on the panel for tonight. He's had some flight cancellations in part related to the storm and the impacts that it's had in the air transport today. He will not be able to join us, so I'm going to take over for both the first presentation as well as the moderator for the course. I would like to introduce the two other panelists that are joining us today. I'm really excited to have them both with us. First is Dr. Wesley Lackey. Dr. Lackey is an orthopedic surgeon and the co-founder of the Midwest Center for Joint Replacement, serving patients in the Indianapolis and Bloomington, Indiana area. So thanks so much for joining us, Dr. Lackey. Also joining us tonight is Dr. David Doherty. Dr. Doherty is an assistant professor in the Department of Orthopedic Surgery at McGovern Medical School at the University of Texas Health Sciences Center in Houston at UT Health. And the combination of the talks tonight, I think, really puts together a very nice discussion around the Aurum technology, the role of sort of an intelligent design and efficiencies that can be inherently added to our operating rooms to help improve both our lives as well as the lives of our patients. I'm going to start with the first presentation tonight. So I have sort of a two-part task, partly taking over Dr. Bolognese's role a little bit, but also it's trying to help establish a little bit of what my philosophies and thought process around eliminating cobalt chrome and total knee arthroplasty is, and why I think we are headed that way in joint replacement. And then I'm going to introduce and talk to you a little bit about the Aurum technology that Total Joint Orthopedics has come out with. I do have some relevant disclosures, that most importantly being that I am a consultant and do receive royalties, and I'm on the universal design team for Total Joint Orthopedics. I do work with other companies that some of them are listed below. So first of all, why do we need an alternative to cobalt chrome? I think it's important always when we talk about orthopedics and material properties and what we're doing is to think about the history. Cobalt chrome was really kind of discovered in the early 1900s by fusing cobalt and chromium together. The alloy was discovered with many other elements such as tungsten and molybdenum to be present in it. And Elwood Haynes kind of reported that the alloy was capable of resisting oxidation and corrosive fumes, existed and exhibited no visible signs of tarnish. It became intriguing in the medical device era. In 1960s, it was first implanted in prosthetic heart valves, interestingly, and lasted for many years, including in 1990s, still showing high resistance to wear. And due to its excellent resistant properties, the biocompatibility, high melting points, and incredible strength, even at high temperatures, cobalt chrome alloys were found to be a suitable use for material and joint replacement. It demonstrated some resistance to corrosion due to the spontaneous formation of the protective passive layer of chromium oxide. So if we have such a great option, why are we getting rid of it? And I think most of us that do total knee replacement also have done or trained in or currently do total hip replacement and even revision total hip replacement. And many of us have seen a dramatic shift away from the use of cobalt chromium and total hip replacement. We haven't quite seen that yet in total knee arthroplasty, and maybe that's because we haven't realized some of the detriment or seen some of the problems or understood what it is. Similar to that, in my opinion, to what we were seeing in the early 2000s when we didn't really know what the problem that was brewing was. With cobalt chrome in general, not just in hip replacement, but in all parts of the body, we can see issues with corrosion, mechanically assisted crevice corrosion at taper junctions, some local toxicities, adverse local tissue responses. I'm going to talk just briefly about allergy and hypersensitivity, and then we're going to hear another talk about it later. The issue of wear, also the issue of infection has been brought up. And some of the advantages to the use of ceramics in total hip arthroplasty. And I'll show a couple examples of how I think that might also translate into the knee world, and the systemic effects of cobalt chrome ions I'm only going to mention cancer once. We really don't have any good clinical data suggesting it other than free cobalt powders. But it is important to note that our European colleagues are now having to add a label to their packaging for any implants containing cobalt chromium as a potential carcinogen. Some of the examples on the right-hand side showing large diameter metal on metal and dual modular junction total hip arthroplasty, some of the areas where I started to really become keened in on the issue of cobalt chrome and how I've started to translate some of those findings to the world of knee replacement. As I mentioned, all of us have seen this dramatic shift. This was the 2021 AJRR report, which was the most recently available publication. And you can see that dramatic change in the crossover point happening around 2014, where dramatic increases in the utilization of ceramics occurred at the same time with the dramatic decreasing utilization of cobalt chrome. It may have been popular at the beginning of my career to do demand matching based on the patient's age or their insurance or where I was operating to use cobalt chrome versus ceramic, whereas I use 100% ceramic heads in setting of total hip arthroplasty for many reasons, corrosion only being one of several of the reasons that I think many of us have moved away from the use of cobalt chrome. So as I mentioned all that list above, many people are saying, aren't those just total hip arthroplasty issues? And my argument is no. I want to address the elephant in the room first when we're talking about alternatives to the cobalt chrome in the setting of total knee arthroplasty, and that is that of metal sensitivity or allergy. That's the most common use for alternatives to cobalt chrome. If you look at what the indications for alternatives in total knee arthroplasty currently exist are, I think it's still a relatively controversial topic. I think metal sensitivity has been shown to be a potential real issue, a type 4 hypersensitivity. None of the tests that we have existing are actually validated. Skin patch testing, I'll get to in just a second, I don't think really is a great test for someone with a deep organ space orthopedic device or implant. And then the issues of lymphocyte transformation tests, there's a couple commercially available, and we've seen examples in our own practice as well as other colleagues where you can get same patient, do the lymphocyte transformation test and the other alternative option, and both of them will have exactly opposite answers. And I'm not convinced that I know exactly what to do with that information. It does make a little bit of sense to take the patient's blood cells and react them. We don't really know what to do with it. Ultimately, if you really think about it, we talk about nickel allergy and setting a total knee. A cobalt chrome implant actually only contains 0.4% of nickel. The stainless steel implants that we commonly use in our trauma world contain 13% nickel, and we very rarely discuss the issue of pain after fracture fixation being related to nickel allergy. On rare occasion, we might see an indication for alternatives like titanium over a stainless steel implant, but it's rare. And again, getting to this issue of the skin being a poor surrogate, in my opinion, it's a very different immune system. It's the barrier to the outside world, to our inside world. It has Langerhans cells, dermal dendrocytic cells, and these different ways of keeping bacteria, viruses, and other foreign materials out of our inside space. And it's just not the same immune system. So I think skin patch testing doesn't really hold a lot of weight in my practice, at least for diagnosing the issue of allergy. But I get to the issue of, is it real? In this particular publication, kind of looking at it, talking about, although cutaneous and systemic hypersensitivity to metal has arisen, there is increasing concern after joint replacements, but allergies against implant materials remain quite rare and are not a well-known problem. And I just want to take it back to the hip world. We've seen a couple of recent publications talking about our instruments. We use stainless steel blades and other instruments in total hip arthroplasty as well. The issue of our saw blades and our instrument cutting guides creating metal debris at the time of doing the total knee arthroplasty probably gets washed out by our body. And that's not really where I think we should be focused, but really on the long-term benefits and long-term effects of cobalt chrome in the body. And if you talked about the hip world, and you had a metal on poly total hip arthroplasty, as was a patient of mine that I revised a few years back and had this massive pseudotumor as a result of likely corrosion at the taper junction. There's very few of us that probably would have said, oh, this patient's pain and swelling in the hip must be related to a nickel allergy. It's almost mind-boggling that any of us would think that today. I very rarely would bring up nickel allergy in the setting of a diagnostic workup of a patient's issues with painful total hip arthroplasty, and yet that's one of the most common things we jump to a conclusion in total knee arthroplasty. So does corrosion occur in total knee arthroplasty? I talked about it in total hip. My answer is yes. Modular junctions, particularly in revision total knee arthroplasty, are common and prevalent. There's various ways we obtain fixation. Certain, I think, implants are a little bit higher risk, where we actually do a sort of poor job of cementing in an effort to try to improve sort of zone 2 metaphyseal fixation. We can see erosion, as you can see in this picture of the bone from underneath the cement that was probably adherent or at least adjacent to the bone at one time. And now we have a dangling large lever arm of the entire weight of the leg on a tapered junction. This is a case of mine I did a few months ago of a pseudotumor actually that had formed in this patient. Negative infectious workup. We weren't able to get synovial fluid metal ions. What you can see in this video is this sort of cystic and solid pseudotumor that was directly adjacent to the corrosion occurring from the well ingrown but cobalt chrome through titanium junction, where corrosion can occur, where there can be micromotion. Other areas of revision total knee arthroplasty with stems, we all use some sort of stem likely in our revision setting, some of them being fully cemented. I think a little even higher risk is the non-cemented, where we try to get fixation to diaphysis, don't have cement supporting the modular junction. And if we get loosening or any changes distally, now we have stresses on a Morris taper. And a couple of papers that Guo-Chin Lee and his team have been a part of, showing that there can be corrosion, fretting, and material loss at these modular junctions in the setting of revision total knee arthroplasty. One more sort of similar example to the case that I show with the video. This is a different patient, but a very similar scenario where we had well-fixed implants with good osseous integration in zone 2. But what you can see is corrosion occurring of the base plate that doesn't have a lot of epiphyseal segment fixation, sitting in trying to dangle inside of a titanium sleeve, and significant corrosion demonstrated at that conical junction and the pseudotumorous tissue that was excised at the time. All right, so I mentioned it's in modular junctions. We don't have modular junctions in primary total knee arthroplasty. So why the heck am I talking about it in primary knee replacement if that's the solution that I'm sort of getting to here? Well, I would argue that we still have cobalt chrome in the body, even if it's not a modular junction. And even in the setting of primary total knee arthroplasty, elevated metal ions in the setting of unilateral and bilateral total knee arthroplasty have been demonstrated in multiple sort of case series and other sort of prospective and retrospective studies. This is just one example that was published in Core in 2007. Here's another example. Cobalt levels were low. Many of us would use a number or a threshold of concern about metal ions of 1 microgram per liter in the blood as being concerning, but all of them were elevated compared to controls, although less than 1 in this particular study. And the authors questioned what the potential local effects of metal ions being released from the primary knee replacements could be. There is surface damage of cobalt chrome implants, even without modular junctions. Surface damage, corrosion, and cobalt chrome debris was seen in 98% of retrievals in this particular publication. And a 12% by weight of wear products were actually metallic wear products, not just polyethylene wear. As we might imagine, we see that scratching that we all can see on the ends of cobalt chrome implants. Yes, it's going to wear the polyethylene and create poly debris, but there's metal debris that's also being released in the setting of scratching as well. And there could be, potentially immunotoxic effects, and maybe even some of these issues of pain, swelling, this sort of elusive effusion in the patients with the painful total knee that we can't kind of diagnose. So what about infection? I mentioned this earlier. The dental world's always an interesting area to go. We've heard that the recent sort of potential theories, as best I could put them, about the ceramics and total hip arthroplasty, potentially a little improved wettability, reduced surface adhesion of the bacteria or biofilm, maybe reducing the local tissue toxicity by the lack of cobalt chrome toxicity, creating the immunomodulation, decreased wear, leading to a little lower particulate load, therefore a little less inflamed joint environment. There's a lot of theories. This is an example in dental world of a titanium nitride. And I bring this up because this is where we're getting into this discussion on the Aurum technology and total knee arthroplasty as total joint orthopedics has come out with. It's a titanium nitride, perhaps a little bit different than the one used in the dental world. But you can see here significantly lower amounts and adhesion of biofilms to the Ti-Ni surface substrate compared to the titanium substrate of the dental implants. So what about the role of materials? I just bring up this little graphic that I got on the email just before this. That's also being released by Orthopedics this week, I think in the coming weeks, about implant alignment. This is from a different company, obviously, but we all know about dissatisfaction in this 20% group of patients that we have after total knee arthroplasty. And we often talk about a lot of alternative factors, kinematic alignment versus mechanical alignment, the type of soft tissue balancing, the use of robotics, the type of fixation with cement. cementless, hybrid, the kinematics of the joint, the PS versus congruent versus CR, bearing designs, etc. All of these are factors being discussed. What you rarely hear discussed are the material properties that may affect the issues that I talked about with the immunomodulation and potential pain sources. So just like Indiana Jones searching for the ideal material or gold here, just because we stumbled on a cobalt chrome in the 1960s and total knee arthroplasty doesn't really mean we discovered the best material. And my opinion is it might be time to reassess the role of the material being used in total knee arthroplasty as one more of those variables as we try to attack that 15 to 20% dissatisfaction rate, improve outcomes, longevity, and improvement in wear. How does it present as far as metal issues? If we talked about pain, that's really it in my opinion. We talk about the hypersensitivity with the cutaneous reaction. Again, it's very rare. What is very common in my revision arthroplasty referral practice to see patients with that painful total knee replacement with swelling and not really a better diagnosis. I've started to think about the metal issue a little bit more, and that's really how some of these patients have been shown in this particular publication. Just a case series, 6 knees talking about a painful effusion of cobalt chromium. Stephen Tower is an interesting guy. He's one of us. He's lived this and had metal on metal toe-lip arthroplasty. You can see his story. If you go to anywhere on the internet, he's got it. He's part of the documentary of The Bleeding Edge that's on Netflix and has a very high view rate. He's published multiply, and he's talked about it on his own on the circuit with TED Talks and has been published in the New York Times. He's somebody that we ought to listen to, and he's pretty thoughtful about this issue. And he's published this in JAMA. I think we're going to hear about this again. But he's broken this down into extreme risk joint replacements being metal on metal toe-lip arthroplasty, high risk including bilateral total knee arthroplasty primaries, and then low risk including ceramic on poly, as well as the unilateral primary cobalt chrome. Cobalt chrome in the blood can be shown in any of these risk categories, the higher risk being the most. But one of the most concerning things is even with very low numbers, as low as 1.1 parts per billion in the urine and 4.1, we can see cobalt-related encephalopathy. He's talked about this a lot with some studies that he's done with FDG PET brain scan imaging, talking about various tiers, but significant hypometabolism being seen in the brain with increasing levels of cobalt and chromium. We've talked about cardiac myopathies, sensory differences. One of the ways that Stephen recognized his own metallosis disease was the fact that he had really a sort of a mental and psychotic factor that really changed his life when he got his revisions and had decreasing loads. His mentation improved, and he's moved on to now trying to help kind of get at this issue for all of us. So now I'm going to finally focus on what is Aurum. Is there a solution to all of this? We've heard about alternative bearings, as I mentioned, mostly for allergy. This is a different option, okay? And it's, I think, an improved option. It's a superior option than the others that existed for multiple reasons. It's an ion-bombarded, ballistically bonded tinitride coating. It establishes this ceramicized coating that we've heard about with other implants, but it's stronger, it's more scratch-proof than cobalt chrome. It's able to resist forces to prevent breakage and also resist scratching and decreases wear. Why is it better and how is it better than the other Tinite coatings? It's not a coating, it's a surface transformation. It doesn't add any of the cobalt chrome or nickel sensitizers. And it does this by taking this ion beam enhanced deposition process and ballistically bonding, or a surface transformation. It's not a coating, but it's surfacely transforming the surface of titanium substrate, this TiAL substrate, with this iBed technology. And the way it's doing this is taking nitrogen ion beams and a titanium evaporant and not baking it on. It's not a heat or thermal process, but it's rather an energy process. It's ballistically bonding it with kinetic energy and slamming these ions against the titanium alloy. And that creates the surface transformation as opposed to just a coating that can flake or chip off. So it demonstrates very good surface hardness, it's durable, and exceptional wear properties. Is it a good solution? As I mentioned, it's strong. So we've cycled it in Instron machines to 3,000 newtons, and it demonstrates adequate as well as enhanced durability compared to cobalt chrome. And this is an example of cobalt chrome on a block that's been cycled with 400 grit sandpaper. This is Aurum, the titanium nitride Aurum technology from Total Joint Orthopedics that's also been cycled the same number of cycles, the same grit surface of sandpaper, and you can barely see a scratch. You can see the, sort of full reflection of the engineer here with their iPhone. It looks like this when you look at it on a scratch graph. When you put it in a wear simulator against polyethylene, unscratched cobalt chrome versus unscratched Aurum, it already looks better. Now you scratch it, Aurum looks dramatically better, statistically significant improvements in wear when you add scratching. And that's basically kind of simulating what it would be like to have this implant embedded in a human for a long period of time. Even taking a ceramic pin and literally trying to like grind the surface down. Titanium is a soft substrate, right? So it is easy to scratch. Cobalt chrome is more resistant. That's kind of how we settled onto it. It's a pretty durable surface, but as we've shown, it's easy to scratch despite that durability. Well, you do this iBed Tynite surface transformation with the Aurum technology, it's even better than that of cobalt chrome and resisting the scratch of a ceramic pin grinding against the surface. As I mentioned, there are other alternatives, whether it's from the Oxinium, Ion Guard, Tynite, 7-layer surface wrapping of cobalt chrome as a substrate that may have some issues with some flaking, as we've been demonstrated in some case series. This is an example of my own revision of a case of where the Ion Guard surface that it was used that got aseptically loosened. There was particulate and third body debris from the abrasive wear of cement on the backside that got into it. And it's really, really poor. It's a resistance at scratching when you add sort of the abrasion. As you saw with the Aurum technology and even using sandpaper directly against it, it's quite resistant to surface scratching. And again, that gets to this ballistically bonded zone. It's an additive 5-micron layer surface transformation above that, which is different than other alternatives on the market. And then that's just one more snapshot of that exact same picture. I've shown how they perform that with that ballistically bonded zone by the kinetic energy. So in summary, cobalt chrome may have additional problems that we haven't fully recognized, potentially due to our lack of awareness. And my most, sort of relevant sort of analogy that I could come up with is that of our era of the early 2000s in cobalt chrome, metal on poly total hip arthroplasty, metal on metal total hip arthroplasty, the modular junctions of dual modular taper total hip arthroplasties. And why is it any different on the other side of the femur and the hip when we're talking about a knee? Flip the world upside down and now we're in the knee. And these issues are probably there. We just haven't really thought a lot about it or done a lot of studies. But if I showed you, as I have shown you, there are several studies that demonstrate metal ions, debris, scratching of cobalt chrome, and this may not be the superior option, not just for allergy issues, but also as a durable sort of long-term solution, a high-performance bearing option to help improve our outcomes in total knee arthroplasty. Thanks so much. So after that rapid fire review of what Aurum is, I'd really like to now introduce Dr. Wesley Lackey, again, of Midwest Center for Joint Replacement. And he's going to talk to us a little bit more about his use of the total joint orthopedics implant, the one knee system, and his use of Aurum even in his private practice setting. So thanks, Dr. Lackey.
Thanks, Dr. Pelt. So I'm going to be talking about Aurum and the classic knee in general in the ASC setting. My disclosures relevant is that I consult and design with Total Joint Orthopedics. So last week was CST week. And so in addition to lots of treats and cookies around the hospital and surgery center, there were memes flowing. And this is one I pulled. Surgeons be like, why are my turnover times so high? It doesn't matter if you're private or group or employed or in an ASC setting or a hospital setting, there is value in simplicity of performing our craft. And so I would argue that you don't need 70 trays and 15 femur options and that kind of stuff to perform a simple total knee arthroplasty and get a great outcome. And the classic knee system, I think, is a fantastic workhorse in any setting because it, with one set of instrumentation, you can move back and forth between many options. You can do a cementless total knee. You can do a cemented total knee. You can do a CR or a PS. You can cut a box or not and use an ultracongruent PS technique bearing. You can use a titanium or an all poly tibia. You can add stems and do a fair number of revisions at this point, more to come later on that. So whether it's primary, complex, complex primary, some revisions, or even this all poly tibia, which is a go-to, especially the ultra congruent version, is a go-to antibiotic spacer for us. It's been a great system. And now adding Aurum to that has been a fantastic addition, particularly for us in our ASCs. When we have the patients with the mysterious metal allergy, I always tell them that I don't think that I've ever truly seen a true metal allergy, but I do agree with the problems with cobalt chrome, the unanswered questions about patient satisfaction, the knee that looks great but feels bad. And so in the past, we would go to an alternative bearing surface, which would double or triple the price of the implant. And so that was a high cost to pay for really treating the patient's brain more than their knee. But this has been a great option. We do have an extensive experience with the all titanium Vanguard. That was our go-to non-cobalt chrome implant. Titanium soft on poly is not a great idea, especially in the hip, but on durable poly, it did pretty well. And that may be partly due to the inertness of titanium and the biocompatibility. Now we have a super hard, durable surface along with the biocompatibility of titanium. And the great thing is that all of this fits within one tray. The one tray system really simplifies our life in the ASC and in the hospital. And it turns out, interestingly, that the one tray manufacturer is in our backyard, when we didn't know that for the last 10 years until this recently came out in the last year or two near our office. Here's Dr. Bolo. He's pumped because he's got one tray. He's excited about the cost, the simplicity of sterilization, less room for error, less inventory, less space taken up in the surgery center or the OR at the hospital. And especially here we have fewer workers' comp claims due to less tray hauling. And I would argue that arthroplasty is a team sport, and we need to take care of both ourselves and all of our team members. And so this is a great way to simplify things. Even the packaging is smaller, and that makes a difference nowadays. Looking at when I first started 10 years ago in Mooresville, looking at what the inventory looked like, it was pretty darn streamlined. It was, just a couple options. Now there's 10 companies. They each have a warehouse full of inventory. And so smaller packaging, universal components as opposed to rights and lefts can provide great simplicity and still fantastic outcomes. And we'll look more at that. So again, the evolution of stability, you can go from a congruent CR to an ultra PS, non-boxed, but ultra congruent implant that comes in with titanium tray or all poly. You can easily convert intraoperatively to a PS box if you need constraint. And it's super simple. We open a small peel pack that has a few instruments, a reamer and a clip on a trial. And it's one ream to create the box, 2 rongeur bites, and you're ready to go. And you can do that on the fly, minimal instrumentation change, minimal cost increase. And it's really a fantastic option. You can also stem the tibia. So bad bone or a uni conversion or even simple revisions, you've got a great option there. In the future, I think we'll see the femur, the PS femur is stem ready, and those will be coming out soon. I think we'll get tibial augments on the market soon as well, where this will be a useful platform from everything from primary to a fair number of our revisions. And also it's a bone sparing procedure. Here is up in the corner a chart of how much bone is taken with different common implants, and it's really the most bone sparing. And I love that it's not a box to reduce fracture stress risers. In the past, if we needed to all of a sudden, a couple times a year, bail on a primary to a constrained, if they had the kind of MCL repair 40 years ago, and it's just not robust, and I don't trust it. We're going to switch to a constrained. We got to open all new sets. Our price just tripled, and it's a lot of extra work and headache. When here you can create a great result for your patient with minimal additional effort. So the universal femoral components, I know the tibia was based off of tibial sizes from a ton of specimens. The femoral implant has the patented double Q angle, which just means the patella tracks great on either side. Again, this cuts your inventory in half without any compromise to the patient. Here is a paper we've just submitted looking at close to 1,000 knees, total knees, and close to 700 unis, looking at the patellofemoral joint, anterior knee pain, and stair function scores. And ignoring the patella with multiple recorded cartilage wears in our unis, as well as selective resurfacing, both with anatomic sided implants and this universal femur, we saw no difference in any group across these. So it's a great implant, and we've had great results with very few resurfacings. I've loved the all poly tibia in the outpatient space. It's super efficient. It's a price performer. It may be we would call it the new old gold standard. It is bio-friendly, infection-friendly, bone-friendly, and we put all our tibias in one piece anyway, so why not use it, eliminate one more modular junction. Though I will say their locking mechanism with screw is super robust and dependable. So again, lots of great options, whatever your flavor is. If you want to put this knee in with the robot, you can do it. Lots of options. So here's my first case of the Aurum. It came out in April. Or came to me available in April. Did my first case. So here's the 3-month X-ray. So an all poly tibia with a titanium Aurum femur. Could this be a new paradigm of simplicity, biocompatibility, lightweight, low cost implant? I think I am definitely moving that direction. I would initially, when this came out, I would have maybe said, well, what problem am I trying to fix in my total knees? Because quote unquote, they all do great, like all surgeons say. But seeing more and more evidence against cobalt chrome, even in the well-performing knee, and more confidence in the Aurum implant with the friendliness of titanium and the hardness and durability of the surface, which may have future wear and infection benefits, is definitely appealing. So the classic knee system, it's got all the options you need and none that you don't. It's cost, space, and complexity savings help you, your institution, your staff, and your patient. And I do think that the future may be golden. Thank you.
Dr. Lackey, thank you so much. That was a wonderful presentation highlighting the classic knee system, one tray, some of the different bearing options, and Aurum in your private practice and ASC environment. Really appreciate it. We'll come back to some questions that I'm sure that some of our participants will want to ask of you in a later time. I now want to reintroduce Dr. David Doherty from UT Health at Houston. He's going to talk to us a little bit more about his indications for the use of Aurum technology and total knee arthroplasty in his academic environment at UT Health.
Thank you very much, Dr. Pelt. Glad to be on this call, and I think this is an exciting topic to talk about. I'm from down in Houston, Texas, and quickly, my disclosure is total joint orthopedics consultant. And so briefly, why I use TJO, why I use Aurum technology. I grew up with TJO. Essentially, I used it in residency, I used it in fellowship, and I think it's a truly surgeon-centered company. I think that they care a lot about their surgeons. They care a lot about their patients, their core values of optimizing efficiency. And they also provide tremendous educational support, and they, I think, recognize the need for training the next generation of surgeons. And I think TJO truly does add value to my practice. So with Aurum specifically, I think that they continue along this trend of being patient and surgeon-centered. I think that they are trying to address significant biomechanical issues and real-world issues that we see in our clinics and see with our patients on a day-to-day basis. Just to reiterate the more detailed version that Dr. Pelt went over, but I think Aurum technology is certainly exciting, and I think that the way that it is applied to the titanium is the true breakthrough of the Aurum technology. The ion blasting and the ballistic bonding of the Aurum layer is, I think, excellent for longevity, and clearly it offers significant biomechanical advantages. So a typical patient that I see, and we all see daily in our clinics, is a 59-year-old male coming in. He's got bilateral knee pain. He's been being conservatively managed by a primary care doctor for several years, was told to wait it out as long as he could, wait until he was 60 to get a total knee replacement. Comes to our clinic, he's tried everything. He's looking for total knee replacement, and he comes in. So typical patient that I'm seeing with the residents and the fellows. So he is here for a specific reason. So our job is to find the specific aspects of this patient to customize his treatment plan, make sure everything is going to go as good as it can for him. So he is unremarkable on exam. He's fairly typical. The most remarkable aspects are going to be his BMI. He's a little bit overweight. And he also has mild eczema on his wrists and elbows. And I bring that up. I know that there's been a lot of talk about the possibility of hypersensitivity, allergy with metal ions. And I too believe that we don't really know how to explain it effectively at this point. And perhaps this is something to do with sensitivity just to the metal ions. It might not be an immune modulated phenomenon, but I do think that certain patients do raise my concern level, and patients that do have some cutaneous findings or other signs of hypersensitivity, I do take a little bit harder look at and consider other bearing surfaces other than just cobalt chrome. And then finally, I think an important thing, the social history. This patient works as a laborer on construction sites. He plans to work for many more years. He's an active individual, and he relies on his body, his knees, for his livelihood. So this patient has end-stage osteoarthritis of his bilateral knees. Our plan is for a staged bilateral total knee arthroplasty. And so now we want to optimize our chances for long-term success for our patient. My biggest considerations, as we just discussed, BMI, his social job profession, his age, and then the skin findings as well. What will help us come to the proper conclusion for the patient, always looking at the literature, looking at evidence, and seeing what trends are out there. So a classic paper we've already discussed, just to reiterate, people are starting to see the problems with cobalt chrome. And if over half of the retrieval implants, are up to 98% of them, have scratching and have significant surface damage on them, that's a problem. The highest incidence of these retrievals having significant roughness and scratches on them were in patients that had them removed for aseptic loosening, so perhaps a correlation there. Then also this surface roughness and significant abrasions were correlated with patients' weight and the AP congruity of implants. I'm a user of the ultra congruent implants. I think it's an excellent option, especially in the TJO lineup. And so that's certainly a consideration for me as well. The more surface contact on those cobalt chrome implants can lead to more significant findings. Another paper, more recent, looking at another biomechanical aspect of surface roughness and scratching in cobalt chrome implants versus ceramic or other femoral components. There's a logarithmic increase in the surface roughness during the first 1,000 cycles in simulated load testing. After that, it's a linear relationship. It continues to worsen. The surface material lost is also not reabsorbed readily. It creates third body wear particles, and this is going to exacerbate the scratching and the roughness of the surface of these implants. And these scratches and this roughness in the cobalt chromium implants were not observed in the other bearing surfaces that were looked at in this study. And then finally, to again, kind of come back to the point of the problematic aspects of having cobalt in your bloodstream and the potential complications it can cause to your just systematic, the effects on your entire body. I thought that one of the most incredible quotes from this paper was that systemic cobalt dissemination can result in brain hypometabolism and atrophy in patients with levels of cobalt in their blood as low as 1.1 parts per billion and in urine as low as 4.1 parts per billion are reported to have cobalt encephalopathy. And as y'all saw in the chart that Dr. Pelt presented earlier, there were a lot of patients that were significantly above those levels. Even patients with single unilateral total knee arthroplasty had detectable cobalt levels in their blood and in their urine. So this is a problem. This is something that patients are being exposed to. This can be, this is an iatrogenic problem that we are creating for these patients. And if it's a problem, it should be addressed. So I think that the considerations that we had in our patient, high BMI, his job status, his age, his skin findings, this discussion with the residents and the fellows, it leads to alternate bearing surface. We should not use cobalt chromium in this patient. And for a patient like this, who's looking for knee replacement that's going to be wear resistant, have increased hardness, is abrasion resistant, and avoids the sensitizing metals, and is going to last for a long time for him, Aurum is an excellent option. So that's exactly what he got. He had his bilateral knee replacements done about 2 months apart from each other, and he is now doing great. He's 4 months out on the left one. He's 2 months out on the right. He's back at work. He's on a construction site. He's doing everything he needs to do. He's improving. All of his post-operative x-rays have been consistent, been no changes, no early failure, no polywear, no other concerning signs of loosening that to speak of. So some of my conclusions, I think that cobalt chromium is becoming more and more of a problematic aspect of joint replacement. I think that the jury is still out. I think that there's many more studies that need to be done, but it is certainly an area of concern that I think we should all be considering for our patients. And when there do become things that are potentially better, I think that Aurum fits the bill and it offers characteristics important for all of our patients, particularly high demand patients. And I think that Aurum's great because it is a trusted implant design. It's simply a change in the coating of the implant, and it expands upon a spectrum of total knee products that allow surgeons and trainees and everybody I work with to tailor custom treatment plans to patients. And so I enjoy using Aurum and I enjoy using TJO, and I think it's a great combination and a great solution for a potential problem that we've not fully addressed yet.
That was great. Thanks, Dave. That's a fantastic summary of a great clinical case presentation and some of your indications, some of the interesting conversations you even have with your trainees about indications for alternative options and materials and properties. I'm going to go back to address two of the outstanding questions. I've answered a few in the live Q&A by typing. I have a slide or two that might help us to kind of address two questions that are being asked. One of them is the head-to-head comparisons of more conventionally deposited tie-dye coatings. The second question that was being asked is, there are some papers that are showing failures of tie-dye coatings in clinical practice. How can we be sure that Aurum addresses the challenges that we have seen in those other examples? While I'm pulling up my slides, maybe I would let the two of you guys address how are you rationalizing these potential concerns in your own practice and the decision that you made when you looked at what data is available in the early tests and stuff. How did you choose that Aurum was a superior option and why it was okay for you to use on your own patients in your own practice?
So I think that the biomechanical data and the scratch testing on the Aurum product was it was significant for me in terms of making that determination. I think that when you look at the ability of the surface to maintain after significant attempts to abrase it and essentially destroy it, I think that that's exactly what I'm looking for, because there has been history of some surface coatings not being quite as bonded to the substrate. And I think that when you look at some of the more popular bonded elements out there, I think that having essentially a bonded zone where there's a transition zone where there is interdigitation. I know that's the wrong word, but there is interdigitation between the two materials, and the bonding has a more secure fit to the substrate. And so that's a motivating factor, that the specific way it is bonded is, I think, very important to me. And I think it demonstrates the durability of it.
So I'm just, so Dr. Lackey, maybe you could give your impression. I'm going to show these few examples of comparisons.
Yeah, I agree all that's been said. Our experience in the past was with plain titanium, and we like the friendliness to that. And if you have really great poly, that's good. But what I didn't want to do is introduce a new problem. But having seen the biomechanical testing, the material, I didn't go 100% in, but I'm moving more and more towards that of being all in. We're also, I've seen a little bit behind the scenes as we've been working on developing this. The last frontier of cobalt chrome in the hip has been the dual mobility. But it's better to put a cobalt chrome liner in than to dislocate acutely. But look and watch this space for this Aurum technology coming out in dual mobility hip as well.
Yeah, that's a great glimpse into the future. I agree. Somebody asked earlier, also porous or cementless fixations also, I think, coming out. Here's just a couple of examples of the different ways that Tainai is being added, as well as the only other real true alternative, at least in the United States. We aren't going to talk about ceramics, which aren't FDA approved in the United States, but these all do exist in the marketplace today. What is different is really, in my opinion, this ballistically bonded zone of this Tainai 5-micron surface transformation, additive, but ballistically bonded zone instead of baked on coatings, and the diffusion layers that can be exceedingly thin. And so the example that somebody said about the issue of the softness and the sort of catastrophic failures that have been shown, almost all of those have been demonstrated in the issue of either like the one that I showed of aseptic loosening and the abrasive third body wear that can occur to that very, very, very thin and soft surface transformation layer that existed on that particular implant or other implants, or has been in catastrophic failures where there's been polyethylene failure and the actual implant rubs on another piece of metal. I don't know if anybody has used this particular, you can scratch it with a bovie, you can nick it if you hit it accidentally with your mallet. When we've done the sort of try to damage this surface layer in my own hands and seeing the lab test, the reason that I'm using it is because it's really been truly better than the other things that I've had in my hands before. Granted, it's early. I've used it since February. We just got an answer or a question. Is there any patient or situation that you think Aurum is not the best option? Stated another way, are you using this for all TKAs, and if not, why? The answer for me is I'm using it in all TKAs. 100% of my patients get Aurum. I've eliminated cobalt chrome for about 3 years from my primary total knee arthroplasty practice, and when Aurum came available, it was a easy solution for me. I have partners that choose to spend money on alternative things to get at improvements in outcomes, perhaps in total knee arthroplasty, that also perhaps haven't been demonstrated in the literature to fully make a difference, like robotics, navigation, and others. We can change alignment. I'm choosing to invest that extra cost currently, and it may not always be an extra cost, by the way, as we sort of eliminate cobalt chrome as an offering. We just saw that in total hip arthroplasties. It's really not a price differential in most centers anymore, because the only other thing that's offered is ceramic heads. Well, I think that's probably where the future is heading in total knee arthroplasty as well. Currently, is there a cost differential? Probably. And I'm choosing to invest that in potentially improved, durable, superior material property for my patients. And then this is just one last example, sort of showing the different options that exist, the thicknesses, as you can see. The strongest property that we've been able to demonstrate with this type of technology is with Aurum compared to others. And really, I haven't seen significant downsides. The softer base metal concerning in some of the other implants, the very thin and weaker strength surface transformation or surface coating being the issues with the other failures that have been shown. So I agree with some of the people's concerns, more to come as far as the long-term clinical results. But nonetheless, that is the current technology that we have. Let's see, let's go back. Am I sharing anymore or no? Doesn't look like it. Let's go back to a couple more questions.
And so I can
yeah.
talk about this question from Dr. Peterson, who is asking if there are, the specific types of conversations we're having in the clinic with patients around cobalt chrome, or are they asking about bearing surfaces basically? And I think that there are certainly patients that do come in that are educated enough and do discuss bearing surfaces specifically, but I think that most patients ask questions related to bearing surfaces that are potentially questions that are about bearing surface that they don't realize are necessarily about the bearing surface. And I think our job as a surgeon is to interpret those questions that the patient, and judging their expectation level and their specific patient factors and activity levels to choose the most appropriate bearing surface for them, considering all of those options. I mean, certainly I'm going to accommodate anything a patient is specifically looking for, but in my practice, I still do put in some cobalt chrome knees. However, I'm limiting it as much as possible, and it's becoming fewer and fewer for me. But I think that every patient wants everything. They want the best knee that's going to last as long as it possibly can, and it's going to not cause a secondary problem for them. And I think Aurum represents that so far in early experience for sure.
I mentioned it earlier, cost. Dr. Lackey, could you tell me a little bit about your rationalization or justification of alternative bearings and the increased cost that manufacturers typically apply to those sort of novel implant technologies, and how do you do that and justify that in your practice?
Yeah, so again, whether you own an ASC or are involved with a hospital or managed services agreement or academic center, those kind of things, cost does affect you, especially as we move more and more into higher Medicare groups and bundled payments and different kinds of stuff, cost containment. For me, the TJO system with the options of the all poly, the simplicity of converting if I need to constrain or something, it's a super price performer, cost effective system with low headache, low inventory, and just simple. So yes, the alternative bearing surface does add a cost, but it's significantly less than before. And it was painful to say, hey, I don't really think you have a metal allergy, but you don't like cheap jewelry, so we'll use this $6,000 implant, and that's a total game changer with pricing with TJO.
And you mentioned it in your talk, but maybe just go over it one more time. The efficiency of the instrumentation. You talk about inventory with the universal design, the instrumentation, that same implant I think that you're referring to with that very high cost. When they bring in the instrument trays to do that knee replacement, in my setting, it was probably at least 6 and maybe 9 trays that they had to sterilely process to do one knee replacement. What do you notice different with using TJO?
Yeah, there are some that we kind of make fun of, with rights and lefts and just asymmetric everything, and the inventory is just massive. For us, our predecessor knee that I used before was the Vanguard. But in our ASC, we had already kind of done the one tray system before the one tray came out. So we were pumped about the one tray and the better improved instruments, and they're fantastic. But we do even additional things like peel packing the femoral trials each individually and peel packing each set of poly trials individually. So we have one tray of tools, one tray of cutting jigs and blocks for the femur and tibia, and then we peel pack our trials. And so, so we love to keep it super, super streamlined. And this system has made it even easier to, when the oh shoot moments happen and you need something on backup, it's right there and it's an effortless transition. For us, it's peel one, one extra little set and, one ream and bam, I've got a PS constrained implant ready to go at a very fair cost.
Yeah, that's a great point. There's a couple more questions asking us about costs, and I really think it's the same. I can't give you all a number. I think it's dependent on hospital contracts, just like every answer that any surgeon would generically provide you. In my own experience, I think it's just like Dr. Lackey just said, it's a lot less than what the alternative is. And it's not just the implant cost. When you're talking to hospital administrators, yes, we're talking about lifelong revision risks and superior bearings. We want it to be durable and last and decrease infections and revisions, all that kind of stuff. These are right now all theoretical without proven clinical data to prove it. But there's the whole other thing that Dr. Lackey was just talking about, the efficiency, the reduced inventory, the reduced number of instrument trays and sets, the number of sterilization units that have to go through the sterile processor. For me, I use the one tray, it's one wrap around one instrument tray. And our sterile processing loves it. We can go to the ASC or the main hospital. It makes no difference. And with this current pandemic and this labor shortages, we've got a lot of travelers and different techs in there. It has made the efficiency and the OR so much better because it's simple. And their words over and over again is, this was the best and easiest knee replacement I've ever had a chance to do, because it is so intelligently designed and efficient and streamlined. One tray for the entire surgery. It's pretty awesome. And that's a cost savings in addition to the efficiency with this SP as well. Dr. Doherty, any last thoughts from you?
No, I just think that this is an exciting move forward. I know that, it's been publicized, but I think this is, a good move forward in terms of bearing technology. And, at the very least, it's pushing people to look at cobalt chrome in a different way and recognize that it potentially is not the perfect bearing surface that it once was, and not to say that it hasn't had its time and done a pretty great job for what we've expected. But like we mentioned, now's the time to start tackling that 15 to 20% group of patients and looking for ideas that are going to push this joint replacement field further and truly optimize it all. And I think Aurum represents a strive at that for sure.
Hey, Pelt, it's Bolo. I'm really sorry I'm late. I apologize to everybody. I had some travel challenges, but I was able to listen to you guys. Couldn't have said it any better. Really agree with the efficiency side paired with all the advantages of the bearings, but apologize to the folks that signed in and me not being able to be there with you guys, but I've listened to hear these guys doing a tremendous job. Great job.
Thanks, Bolo. Cameo at the end. I love it.
Yeah,
nice job.
Yeah, but please, you have the last word. But as I listen, you guys really hit all the key points and the reasons why this is such an interesting technology and option for you, and for us, not just for us surgeons, but obviously for the patients.
Great points. So this concludes the hour session that we had for this. This will be available for later viewing, I think, through the Total Joint Orthopedics YouTube channel, their website, and likely through Orthopedics This Week, who is the host of the session today. I want to thank our panelist, Dr. Bolognese, at the very end for his 10 seconds of effort, as well as Dr. Doherty and Dr. Lackey. A really great conversation. I hope this answers some of the questions. More to come. We'll be publishing our clinical results. Obviously, that is our duty as early adopters of a new technology to report, and honest reporting is important to all us as well. And look forward to the future. It's exciting, and maybe we have found the new gold standard. Let's hope. So thanks, everybody.